In part two of this lecture, we're going to have a look at the natural history of pulpitis, really explaining how the disease progresses and develops, particularly if the cause is not removed. So as you can imagine, when the inflammatory process starts, it does so particularly in relation to whatever cause has caused it. So if it's a carious lesion, the initial point of the pulpitis will be a localized lesion directly related to these tubules that are affected by the carious lesion. Once it starts there though, if it's not removed, it's not checked, inflammation will extend through the whole of the pulp if the caries is not removed or the cause. There is a certain amount of variation in the rate of it and the character of the pulpitis that the patients suffer and so on, and that varies between teeth, it varies between individuals, varies between whatever the etiology actually is. So if we do go back to the beginning, as I indicated, the first thing is that when you have an advancing carious lesion, and I'm going to assume for argument's sake that essentially it is a carious lesion that we're dealing with, that the dentine pulp complex will start to respond to the carious lesion as it moves towards the pulp. So you get tertiary dentine formation. And it is trying to remove the pulp as far as possible from the advancing dental caries. And if it removes far enough and the caries maybe doesn't extend much further, if you get an arrested caries lesion or the caries is removed, well then the pulpitis may halt. So here's our lesion, and then you begin to get the formation of tertiary dentine and the pulp moves away from the lesion. Once you begin to get a little bit beyond that and the pulp starts to get a little affected by the advancing carious lesion, you start to notice certain things. Now, the start of the acute inflammatory process, remember all the way back to your inflammation, acute inflammation has a cellular component, which is a neutrophil, and has a fluid component, which is oedema. And so one of the very earliest stages that you will see is that there's accumulation of fluid within the odontoblast layer. And in the picture here, you can see it looks as if the odontoblast layer has got lots of holes in it. And it's just because there is fluid accumulating at the very early stage of pulpitis. As we continue to move on, then we will see that not only do we have the inflammatory effects, but we begin to see the dentine itself responding in the start of tertiary dentine formation. The inflammatory process has been going on for a little while. You can see that the blood vessels are full of red blood cells. There is an increased blood flow. And we're beginning to see more cells in the background. There are inflammatory cells, neutrophils, some lymphocytes, and other inflammatory cells beginning to appear within the connective tissue of the pulp. So if you get at the very early stage, if you get the carious lesion out, you pretty much got a good chance that this will be a reversible pulpitis and the pulp will respond and will recover from this insult. But if you don't, if you leave it till you get established dentine caries or an established pulpitis, well then the situation is very different. So here's the response to established dental caries. You get a full-blown acute inflammation. Vasodilation throughout the pulp, inflammatory exudate coming out, that's the fluid, the protein-rich fluid that comes out to form edema fluid. Neutrophils start to accumulate, and you begin to get the death of odontoblasts in the face of the inflammatory mediators and the increasing pressure in the pulp. Because this brings us to a particular problem with an inflammatory response in the pulp. You see, the pulp is a closed environment, particularly after root formation is complete and the apexification is complete too. There is going to be one blood vessel in and one vein out, and there's no collateral supply. There's no blood vessels coming in from any other side. So that means that if you end up with compromise to the one blood supply, well then you put the vitality of the pulp in danger. If you have pulpitis in the circumstance where you don't yet have a closed apex, well then this may not be quite so much of a problem. But in the tooth which is a fully formed apex, this is a significant problem. So what then does happen in this closed environment? Well, the inflammatory exudate, that fluid, causes a rise in tissue pressure. And eventually that tissue pressure will exceed the blood pressure in the veins. And so the veins will collapse, blood flow stops, and then you end up with tissue hypoxia. Hypoxia is only copable with for a certain amount of time, and then the pulp will become necrotic. Now that can happen to an individual part of the pulp, or it can happen to the pulp as a whole. So here we have an area here at this particular pulp horn where we've got an area of necrosis of the pulp. So this hypoxia will lead to necrosis. You get more inflammatory mediators released from the necrotic tissue, and so it's not as if you slow down the inflammatory process. In fact, you accelerate it because you're going to get further inflammation and neutrophil accumulation because of the necrotic tissue that's there. And eventually what you might find that you have is that you form an abscess, an area of dead and dying neutrophils in a pulp horn. The rest of the pulp, if it remains vital, might be trying to wall it off because it will make granulation tissue round about it. But generally, once you get to the time of having a pulp abscess, it's very, very painful for the patient, and pulp health is extensively compromised. It's very unlikely that this pulp is now going to survive. From that localized area of necrosis and pulpitis and a pulp abscess, inflammation may then spread to involve the whole of the pulp. If you've got a way for the pus to get out, for example, if the caries cavity is large, the pus may drain into the oral cavity. The patient will get an interesting taste from that, and they may report that. So here we have with a localized area of pulp necrosis, and if that's left completely untreated, you may well end up with necrosis of the whole pulp. Blood supply is compromised and the whole lot dies. One thing that's worth remembering though in terms of the pattern of pulp necrosis that you get is that in multi-rooted teeth that may not always be the case. So for example, here in this case we've got necrosis of the pulp on one side and the root canal system in one part of the tooth. But the other part, for various reasons, may well have maintained vitality. And so you may well find that that is the case, that when you open up into a tooth, you'll go into the area at the base, perhaps of the caries cavity, you'll drop into the pulp chamber, the pulp will be necrotic, it'll just be little stringy grey remnants of pulp that's left. But once you open up the whole of the cavity and start to instrument other canals, you might find that you have to pick the patient off the ceiling if you've not used local anaesthetic, because pulp vitality in other root canals may well have been maintained. The other thing to note, of course, and it's not a subject for this lecture, it's a subject for the next lecture, is that once you get a necrotic pulp, you then have the possibility of spread of that inflammation into the periapical tissues. So essentially the story is, the natural history is, untreated pulpitis leads to pulp necrosis and eventually to periapical pathology. Now, if you remember in the first part, I mentioned this strange thing of chronic open pulpitis, sometimes referred to as chronic hyperplastic pulpitis or a pulp polyp. Now, in this case, two things have happened. There's been an extensive caries lesion, which has resulted in complete breakdown of the crown, but pulp vitality has been maintained. The pulp is still alive. And this happens in the circumstance when you have pulpitis, when you have open apices. So the blood supply can cope with the increase in pressure. Crown disappears, and what you get is this fleshy blob, which is the pulp, open to the oral cavity. It's not as painful, in fact, as you might think. It's relatively insensate. And so it is essentially a mass of granulation tissue in the pulp chamber. It's often ulcerated, although you sometimes can get it covered by epithelium, and it will often bleed when you probe it. So here's what it looks like histologically. You can see again we have a tooth, a decalcified section of a tooth. It's a molar tooth with an extensive caries lesion which resulted in loss of most of the crown. But the pulp has now extended out of the pulp chamber, and there is this polyp. Here's the remains of the roof of the pulp chamber, and that is perfectly viable, and you can see that in the mouth. Often these teeth are really quite difficult to extract because they are so extensively carious. They sometimes just squish when you put a pair of forceps on them. So what happens in terms of resolution and healing of the pulp? What capacity is there for the pulp to heal? Now, I showed you earlier on that we're really probably only going to get proper resolution in the pulp if you get the etiological factor removed in a timely manner before the pulp has become too inflamed. And you can do that if you will get the pulp just to resolve. As I indicated, some lining materials like calcium hydroxide, it can be useful because it stimulates dentine formation and you can get an increased calcific barrier between the carious dentine, if there's any left. If you've had to leave some, for example, very close to a pulp exposure, it might be useful. And then, of course, there's the questions of pulp capping and so on, which, again, I'm not going to go into. I'll leave those in restorative and peds to talk a little bit more about pulp capping and the parameters in which you might decide to do that or extirpate. And then we're back to our elephant. And here we have another elephant. This is up at Sun City in South Africa, another one of Dr. Steenkamp's elephants. And in this case, this elephant had a big infection in this tusk. They took about 3 litres of pus out it when they drained it. But you can see just about in this opening here where they are actually going some form of endodontics. Here's a little bit of calcific barrier beginning to appear. And these are the sort of tools that you have to be able to do elephant endodontics. But there are also some very interesting new things coming on in terms of pulp. And a lot of this, I think, may well be related to that. I spoke way back at the beginning about stem cells and undifferentiated cells that are there. And there are some new targeted therapies, for example, this new drug which was reported a couple of years ago, glycogen synthase kinase, when put into an exposed pulp, increased dramatically the amount of dentine which was formed as a calcific barrier. And here you can see, for example, that you're getting at 6 weeks, you're getting really very, very good repair on a calcific barrier. Whereas if you just put in a bit of collagen sponge or various other MTA, which is a restorative material, you're really getting very little in the way of repair. So this is the sort of thing in terms of being able to use new therapies to promote pulp resolution and regeneration may well come in during your practicing lifetime. One more thing I really wanted to talk about just as we finish is pathological resorption. It's the only other problematic disease process in the pulp. And pathological resorption takes a number of forms. External resorption, I'm not going to deal with very much. Of course, external resorption happens physiologically in terms of the shedding of the primary dentition. But in some cases, in adult teeth, you get it as well for many different reasons. But here I'm really talking about internal resorption, and that's because it's focused on the pulp. Sometimes it can be secondary to pulpitis. The pulp can, when it's inflamed, can essentially start to eat itself. But there is this rather curious condition known as idiopathic internal resorption of the pulp, the so-called pink spot. And this is what it looks like here. And you can see in these teeth and these incisors that there is this thinning of the tooth so much that you can see the pulp shining through, which is why it's got the term pink spot condition. And when you have a look at some of the teeth that are affected in this by a radiograph, you can see it looks as if that pulp is just taking a big bite out of the tooth. And that's really going to be very difficult. That looks as if it's almost out to the periodontal ligament. That tooth really doesn't have any future. And we're not entirely sure why this happens. That's why we call it idiopathic. For some reason, there are osteoclasts or dentinoclasts, if you like, are switched on and they start to eat the tooth from within. And you end up with the lesions that you could see in the previous clinical picture and radiograph. Some further reading there, if you would like to do so, in terms of the relationship of pulpitis with dental caries, and also some more general reading in the appropriate chapter in the new Soames and Southam.